Any questions from the audience?
I have a very practical questions about the NAVA tube positioning. Usually in your clinical practice, do you check the position by a chest radiography before beginning enteral nutrition? Or if you have a correct screen on the ventilator, you just do it?
No, we don't. After changing of the, although it's always discussed in the even current opinion article if it should be done in after general catheter or esophageal or nasogastric tube placement, should there be an X-ray in order to confirm, in order to avoid the associated complications. We don't usually do that. It's a common procedure, and I think the risk is rather low, and it is even lower with regard to NAVA, because you have a screen that shows you that NAVA doesn't work. So that is, besides all the other aspects, auscultation, putting some air in order to hear the bubbles and so on. You have also the catheter when it's going in there, where you don't get the signals you are used to when you want to put a patient on NAVA. So we did that also in animals a couple of times, where we intentionally put the catheter into the tracheal tube in order to see what signals do we see when the catheter is going the false route. And well, we were never able to run a ventilator on a falsely placed catheter. So I can't put a hand into the fire on that, but that's our experience. So we are pretty sure that we don't do it. The only reason why I have the X-ray on that case is that the patient needed an X-ray anyway. So we did this X-ray and said, okay, let's do it now, and then we can confirm that. So that was the only reason. We wouldn't have put him on extra radiation otherwise.
Thank you very much.
Any other question? Yes. Microphone is going there first.
I'm Dr. Shek from Hong Kong. I'm a neurologist, and I'd like to ask, we have tried the NAVA in dose therapy child baby, and find it difficult to keep the catheter in the proper place. Sometimes when the child just move a bit, the signal the bull tracing will go into the first and second, rather than the second and third, or go into the third and fourth. So, is there any risk to run the patient in NAVA when the catheter is so difficult to maintain the proper position, or when the bull signal is in 1, 2 rather than in the second or third tracing? Is there any risk of having the NAVA in this condition?
I try to get the question in line. I'm sorry. So the one question would be.
It's very difficult in a newborn, in those preterm baby, to keep the catheter in the proper position when we see the bull tracing.
Okay, so difficulties in terms of keeping the catheter in place. From your experience.
Yes.
Well, I can confirm this experience. I mean, we can ask the audience. From my point of view, it's not such a big deal. If the patient, the catheter is fixed, probably the catheter tends to be, let's say, thrown in by the diaphragmatic movement. So, and if it's fixed upwards, you get it straightened. So you might initially correct that, but then the catheter usually is in place. And looking at the screenshots were made, it was really just jumping into the ICU, looking at the patient, look at the screen and make the shot, and all the catheters were in place. So, and the nurses are really relaxed on that point, at least in our ICU.
Onnen, I think the question really was in newborns.
Newborns? Oh, no, it didn't.
So I want to 2 mm or 2 to 3 mm.
I didn't got the newborn aspect on that one, so that I need to pass, because I only deal with adult patients in our ICU. So.
We have been using NAVA in our neonatal intensive care unit with the tiniest babies around 500 grams, and for them it's true. Sometimes it's hard to keep the catheter in the right position, because if you move it just a few millimeters, like 2 millimeters. The distances are so short that ventilator may alarm. But in general, it's not a problem for using NAVA with them because the ventilation functions well.
You want to answer us?
I just would like to know what are the indications for NAVA. If I understand correctly, the prolonged cleaning is the one. What are the other indications in your unit to place NAVA?
So we had this question already a couple of times today. From my point of view, I think really weaning and monitoring weaning is a big issue. We might really get a grip on using NAVA, using the mode as well as the monitoring capabilities. We did also NAVA, did a study in post-cardiac surgery patients in the early phase. I don't see that much benefit in these short-term post-operative ICU patients. I see an idea in the decompensated COPD patients. We also use it as a supplement in ECMO patients. Sometimes we have the experimental data where we see that the ventilation is shifted downwards during NAVA compared to other modes of ventilation. So we hope that we facilitate recruitment if the patient has recruitment potential. So there are some aspects, but if you go back to where's the evidence, well, I mean, then we are still sitting here with empty hands. And of course, we know that there's a better synchrony. So any patients who would benefit from that should be put on NAVA, from my point of view.